All right. Good afternoon. This is the May 2015 edition of EMS Medicine Live. This is our fifth webinar. If you can believe it, we've gotten almost half a year into this. This, just a review for everyone who hasn't seen before, Derek's, Brian, and my vision was to create a place for community and academic EMS physicians to share education, share information, and some board preparation for EMS fellowship boards. We do look for group involvement, want to meet and see our peers from across the country, and do look to involve any experiences and skills from different parts of the country. This is your directors. Myself, when I still had hair and a beard, Derek Cooney and Brian Clemency. Myself and Derek are from SUNY Upstate, and Brian is from SUNY Buffalo. Lots of folks have asked in recent months about how to get past presentations. We have created a web page at SUNY Upstate with the link being shown, or you can just Google EMS Medicine Live, and the first link should be EMS Medicine Live. We have a Facebook page, also called EMS Medicine Live. You can find slides on our webpage and copies of presentations on both our webpage and Facebook. We did create a new Google email address for ourselves, emsmedicinelive@gmail.com. If you ever need us, you can email that, and we send out our distribution list for future conferences from that site as well. During the presentation, I think everyone's now muted. I'm going to mute the gentleman from Illinois too, sorry. Just to keep down background noise, which makes it hard to hear. I've started recording, so we can watch this later, but you can also record at your own site if you want to keep a copy. Questions during the conference, chat questions to EMS Medicine Live. It's my second account, which I'll be looking at, and I'll try to either ask during the presentation or ask at the end. You're supposed to be able to raise your hand virtually, which I still haven't quite figured out on the group chat because I don't see it there, but it should be a raise hand, something like this. At the end, feel free to unmute yourself, ask any questions, or just message me and we'll ask questions. If there's any major problems, just send me an email afterwards and we'll see how we can get things better in the future. So today we're lucky we have Chris Tanski, who is a EMS physician here at SUNY Upstate. He did his medical school here, his residency in Albany, and did his fellowship with Brian Clemency at the University of Buffalo. Apparently he enjoys upstate New York and keeps traveling back and forth, but now he's settled with us back at SUNY Upstate last year. He's part of our physician response team. He's been helpful with that and our SWAT team response. He's a DMAT physician for Team 4. And he's a command physician for Mercy Flight West and is heavily involved in critical care transports across the state, especially down to New York City. Today, he's going to be presenting Nerve Agents 201. And with that, I'm going to share the remote control with him, Chris Tanski, and let him take over. I'm going to hide myself so you don't have to look at me.
All right. Well, thank you, Chris. Let me make sure I have control of the screen here appropriately. Let's see.
Here, oh, try again.
Okay, got it. There we go. All right, perfect. Well, thanks for joining us today, whether it's good afternoon or good morning, depending on what time zone you're at. As Chris said, I'm going to be talking about nerve agents today, and I'll be happy to answer any questions that you might have either during the presentation or after it. I, too, do not quite understand the whole raise your hand concept, but if you have a question, we'll certainly try to answer it. This area, this talk is something of somewhat interest to me. I'm not quite sure why. One of my roles that I've had for a while is to do some WND instruction for the Department of Homeland Security. So there are classes that you can take in the different areas, nerve agents, chemical, biological, radiological, and so forth. And I instruct some EMS agencies in those areas. And nerve agents have been a particular area of interest of mine for quite some time. So I titled this talk Nerve Agents 201, which would suggest that it's not a 101 or a basic level class, but we're going to go a little bit more in depth than some other instruction might, just keeping in mind the audience that we're dealing with here, and maybe touch a little bit more on that. We certainly will not go too in depth. You can obviously talk for quite some time about the particular nuances of different agents, and we're not going to get too much into that. But we will try to answer whatever questions you may have. And I'll also talk a little bit about other resources you can use if you should ever find yourself in this sort of a situation. Certainly this applies to EMS medicine as has been evidenced by nerve agent use in the past, whether it was the subway attacks in Japan or other events. This is something we're going to see on the front lines, and our providers are going to see as well, and not just something that we might see in the hospital. As you know, it doesn't apply specifically to nerve agents. It can also apply to organophosphate compounds, insecticides, and so forth, which are still used quite a bit, especially in the agricultural industry. So let's see if this works. All right. I have no financial conflicts of interest or any other types of conflicts of interest with this. So if you've been through any sort of training, you'll know that one of the things that we talk about is the lethal dose of nerve agents. And if you were to use VX, which is one of the newer, so to speak, nerve agents, 1/100th the size of Lincoln's head on the penny is the lethal dose for a drop of that nerve agent. So we certainly are not talking about large quantities here. And when we talk a little bit about the amount of nerve agent that we think is still present around the world, you'll see it's quite a large amount. But this certainly does not need to be present in any sort of large dose to have an effect on folks. All right, well, just a little bit of background. That is Dr. Gerhard Schrader, who has the auspicious title of father of nerve agents. I'm not sure that's something that you would aspire to. They're probably one of the most toxic substances known to man, botulinum being the exception to that, although it does depend to some degree on the particular agent. The agents were developed primarily in Germany, England, and some other countries as well. We certainly have seen use of them dating as far back as 1984 by Iraq. And the most recent use that I'm aware of was 2013. So they still continue to be used. Dr. Schrader was a German scientist working for an agricultural company that was looking to develop insecticides. They discovered palathion, which, as you know, is an insecticide. And they were looking for a new class of chemicals that would be more effective. And the first one they discovered was tabun. And then the rest of them came after that. Shortly after he discovered these chemicals, he was placed in charge of a team by Germany to develop nerve agents to be used as warfare. And the G nerve agents were discovered between 1936 and 1949. The original company, the original German company that developed these is called IG Farben. And that was split up into 4 companies, just as a matter of kind of background. And 3 of those are still in existence today. One of them is BASF, the other is Bayer, maker of aspirin, and the last is Sanofi Aventis. And so those companies were offshoots of the original IG Farben that developed the nerve agents. The Soviets, it's likely as a result of an occupation zone, seized some of the nerve agents, and that's how they got them into their country and made some modifications to them. And you can also see there Dr. Ranajit Ghosh of England, who worked for a UK chemical company developing pesticides, who also worked in the development of these. All right, well, perhaps the most exciting part of the lecture, if nothing else, most of us are mispronouncing these. So if you hear it on the news, it's actually not sarin, it's sarin, and that would be the appropriate pronunciation based on the original documentation from the development in Germany. So I've tried to spell out the nomenclature there, and if you want to be seen in elitist circles in EMS and WMD medicine, you now have the proper pronunciation. So it's tabun, sarin, soman, and cyclosarin. So an interesting question. Military agents obviously are given two-letter abbreviations, so GA, GB, GD, GF. And most people would agree that the G in this case stands for Germany because they were developed by German scientists. And if you were an inquisitive mind, you might want to know, well, why did they skip over GC and GE? Well, for those of us in the medical profession, GC is an acronym that is already used for a very different area of medicine. They didn't want to confuse that. And GE at the time was a company, it still is a company that's heavily involved in military efforts and so forth, and so they did not want to name a nerve agent after that. So they skipped GC and GE, and there are in fact other German nerve agents, G agents, that are much less common. Then we have the V agents, VX being the most popular one of those. These have names as well that you can see here, common names that are not used quite as popularly. I think purple possum is an interesting name for VX, but certainly not something that we would hear all that often. So again, a little bit of information for you. These are quite a bit more toxic. The lethal dose for these, particularly for VX, is about 5 to 10 milligrams. And we already talked about how that's such a small volume of liquid or vapor, as it were. And if you were interested, if you wanted to take a guess as to what the V stands for in V agents, there are several thoughts. I'm not sure anyone knows for sure. One of the things would be that V stands for viscous, indicating the viscosity of these agents. The other would be that V stands for victory, sort of alluding to how they were going to be used in the war effort. And the last thought was that V stands for venomous, reflecting kind of the nature of these chemicals. So I'm not sure that anyone really knows for sure which of them it stands for, but those are the three that I commonly heard referred to and make reference to those. So again, VX is the most common of these, and we'll talk more about that in just a second. So talking a little bit about international control. The Chemical Weapons Convention of 1995 was the first major attempt by the world at large to not only stop the production, obviously, but also to destroy all stockpiles of chemical agents. Now, this is not just nerve agents. It's a number of other things as well, but particularly we're concerned with nerve agents here. Now, it had a rather lofty goal, and that was to destroy all stockpiles of nerve agents by 2007. Well, if you were not aware of that, we're 8 years past that, and we have not really come close to destroying all stockpiles of nerve agents. Now, the U.S. Original deadline, and still the official deadline, was April 29th of 2012. They essentially gave themselves about 10 years after they ratified the convention to destroy them. Now, according to the latest annual report that OPCW put out late last year, they're hoping to have 100% elimination by 2023. So we still have about 8 years to go. And I'll show you in another slide how we're doing with that effort. There are several countries that have not signed the treaty, and you can infer from that whatever you'd like. This is based on countries that are members of the United Nations, so there are other countries that have not signed the treaty that are not members of the UN, and that's not included here. But among members of the UN, those four, Angola, North Korea, Egypt, and South Sudan, have not signed the treaty, although there is a movement in South Sudan as well as Myanmar, which is another country, to sign that. The U.S. has a number of different disposal sites. There have been other ones in the past. I'm certainly not naive enough to think that there are not other places around the country that we are dealing with these sort of things. But there are 3 military sites used. One is Edgewood, the Edgewood Chemical Facility in Maryland. There's also a site in Pueblo, Colorado, and a site in Kentucky as well. As a matter of interest, there is a location where folks like ourselves, first responders, can train with nerve agent. I'm certainly not advertising for this group, but the Center for Domestic Preparedness down in Anniston, Alabama, has a toxic agent facility, a live agent training facility. If you haven't been there, it's a wonderful place to go. You get access to live agent and are suited up appropriately and get to practice medical tasks while you're in the presence of a nerve agent. and it's free for first responders, and it's really a remarkable facility, and I'm happy to talk about that later if people are interested. So there you can see the progress. This is around the world, not just in the United States. The annual report does get specific about certain countries, but we've done a good job with some of the agents, and we're still a bit far behind in others. And if that isn't particularly sobering, I think the fact that we have 9 million kilograms that we know about left in existence probably should give you some pause. Knowing that the lethal dose is 5 to 10 milligrams, especially for VX, there's certainly no shortage of nerve agent, and this is only a nerve agent that OPC knows about and OPCW knows about and reports. But every year they put out an annual report, which you can look at online, and it talks about the numbers that we have relative to how much we had originally, how much has been destroyed. And they also talk a little bit about other aspects, including destruction facilities and progress and so forth. It's an interesting report. The last one came out in the fall of last year, and it's worth reading if you're interested in this sort of thing. But that all aside, let's talk a little bit about the medical aspect of this, which is presumably why we're here today. So these are related to, but not exactly the same thing as organophosphate insecticides. They are in general liquids at standard temperature and pressure. There is some thought that, most of them are colorless and odorless liquids. Now, there is some thought that this applies to fresh nerve agents, and that as a nerve agent ages, it may actually develop a somewhat indistinct odor to it. Certainly, this is not something we want to find out in real life, and it's not something that I have a tremendous amount of information on, but generally fresh nerve agent, whatever that means, is a liquid at standard temperature and pressure. It's volatile, and again, it's colorless and odorless. You can see that the G agents and the V agents differ a little bit there in the terms of their persistence and their volatility. G agents are extremely volatile and not particularly persistent. They don't tend to stick around. V agents are much less volatile and quite persistent. So there we have a little diagram, which I obviously cannot take credit for having done myself. Again, this is supposed to be a little bit more than we would normally do in a basic class. So I'm not going to spend a lot of time talking about how nerve agents work. I think that's fairly apparent probably to most people that are on the conference here. They block the breakdown of acetylcholinesterase and allow block the breakdown of acetylcholine and allow it to accumulate. And you can see there the use of atropine and oximes and benzodiazepines to try to mitigate the effects of nerve agent exposure. And we'll talk a little bit about treatment here in a few minutes, because that certainly would be the most important point of the discussion. Well, the toxidrome is, as most of you know from the various algorithms and abbreviations, it's very similar to insecticide poisoning. Obviously, the toxicity is increased. Certainly, if you were to see a patient in your emergency room or in the field with poisoning by one of the thion insecticides, the treatment is relatively the same. And that may in fact be more common than seeing someone with overt nerve agent exposure. Cholinesterase inhibitors lead to a cholinergic crisis, which is kind of the background of how this works. And one of the things that varies by agent is the reversibility of this. So when we talk about 2-PAM, or pralidoxine chloride, that is used to try to reverse the inhibition of the enzyme. However, some of the agents, as we'll see later, have an aging that's quicker than others, and so some of them are amenable to that, some of them are not. So the antidotes we administer may or may not be effective depending on the time course. There we go. So we know that it affects muscarinic receptors, of which there are a number of different subtypes. And again, not getting into this too much, but there are the M1 through M5 subtypes. And this, as you can see, especially with M3, relates to secretion. So clearly people that are exposed to nerve agent have copious secretions, and especially the pulmonary secretions are the reason for the respiratory distress. And obviously the reason that we use atropine is to try to dry the patient out. So part of this response is a muscarinic response, and these people will, as sludgem or dumbbells, will have secretions in a variety of different ways, and that causes the majority of the problems. We also know that they can also have effects related to seizures as well, and we'll talk about those in a second. So you can pick your acronym. Sludgem is probably the most popular one. Dumbbells, observe, sludgem, RA, bad dumbbells. There's a variety of those. The ones at the bottom take into account that you can see bradycardia as well with this, and so some people prefer those. And I actually don't remember specifically what bag the puddles is, but I always thought that was a good one. I think dumbbells is probably the most accurate one to use, keeping in mind that there are other cardiac effects as well. So we need to talk about different routes of exposure. One of the most common ways this would be used would be a vapor exposure. So the agent off gases and you get exposed to the vapor. This is probably the most dangerous, and it's the one that, generally speaking, has the most serious complications, and it's the one that we really need to be looking for. Now, one of the things that we want to keep in mind is, how do we screen for this? So how do we differentiate this from other things that might cause convulsions and so forth? And one of them is meiosis. So there are obviously certain things in your differential diagnosis for meiosis, but it is a very sensitive indicator. In fact, if you are concerned about exposure to vapor, to nerve agent vapor in a patient, the very first thing you should do is to check their pupils. And in fact, if you go and train in the environment down at in Alabama, where you're working in a room with nerve agent, you'll find that they frequently come up and shine a light in your eyes. And I didn't realize exactly what they were doing initially until I thought about it. And they are checking for meiosis. So it would be my practice, if there was concern about vapor exposure, to check someone's pupils. And if they did not have meiosis and had normal reactive pupils, I would essentially end my concern at that point that they have received a lethal dose of exposure to nerve agent vapor. Now, it certainly is different for exposure to liquid, but particularly vapors, meiosis is sufficiently sensitive enough that you can look for that. And if it's not there, they probably did not have a lethal exposure to nerve agent. So that makes that easy. Certainly, there's going to be decreased vision as a result of the meiosis. One of the things we know from the subway attack in Japan a number of years ago was that many of the casualties complained of decreased vision. That was one of the major presenting complaints, and that, of course, was from the changes in that. Rhinorrhea and salivation, bronchorrhea, this is all, again, evidenced of the secretion effect. And remember, you can also see fasciculations. Death primarily is from respiratory complications. This makes sense, of course. These patients get such profound bronchorrhea and pulmonary edema, essentially, that they kind of drown. So we know that drying them out to minimize the respiratory complications is a very important treatment. And one question that some people often ask is, some of these symptoms, especially the things like the convulsions, can seem similar to cyanide exposure. So is there a way to differentiate nerve agent exposure from cyanide exposure, keeping in mind that, again, the circumstances are obviously going to help you with that as well? Well, the meiosis is something that you're going to see in nerve agent and not in cyanide exposure. So again, that would be one thing that I would look for. The copious secretions are another thing, and the fasciculations are a third thing. And generally speaking, those three signs are going to be present in nerve agent exposure, but not in cyanide exposure. I would not use kind of the color of the skin and so forth, because we know that's not particularly reliable anyway. You can also get liquid exposure. This changes things substantially. You are not going to get meiosis right away because unless you get the liquid in your eyes, but it's going to be the last sign you see. This is going to be a localized phenomenon. So if someone gets some nerve agent on their skin, aside from having the other signs develop as time goes on, that you may get some localized sweating and fasciculations. So this is actually a bit more easy to break down in terms of your differential diagnosis, is there are not a lot of things that are going to cause those type of localized symptoms. However, having said that, we try to think about what would be the method of release if there was a terrorist attack, and that would most likely be vapor, not liquid, because you certainly get more exposure from vapor than you can from trying to disperse a large amount of liquid all over the place. But remember that the signs and symptoms would be localized first in liquid exposure, and then it would actually take quite some time to get meiosis. So there's the differential that we talked about for nerve agent versus cyanide. Again, the skin, I think you can take that or leave it. I'm not sure, that that's a particularly reliable sign for cyanide anyway. And there is an acidosis associated with cyanide that you don't necessarily see with nerve agent. That's not particularly applicable to EMS medicine in the field. Really, it would be more a question of meiosis or not, and are they having profound secretions or not. So this is obviously a talk for EMS professionals. So how do we decontaminate? That's the essential thing. As in all aspects of decontamination, there are certainly particular agents that are better than others. And there are commercially available kits for this sort of thing that you can use. But ultimately, we probably don't have the time or the resources to do that quickly. And so really soap and water decon is appropriate for these patients. Now, we did talk about vapor versus liquid exposure. Obviously, liquid exposure might be a little bit easier to deal with in the sense that you sort of know what you're dealing with and what you have to decon. Vapors can get trapped in the folds of clothing and so forth, so we need to address that by removing the clothing. So there's nothing really unusual here about our pre-hospital decontamination considerations other than remembering to think about it and make sure we do an adequate job of it. And again, you can certainly spend a lot of money on commercially available kits, but I'm not sure that you're going to get anything additional out of that than you would otherwise. So your normal decontamination lines and tents and processes that you use for other chemicals will certainly work appropriately for this. And again, we would need to be working closely with our hospital partners as they would certainly have questions about, is this patient appropriate to bring into the hospital? Have they been decontaminated appropriately and so forth? And certainly people who have liquid on them can off-gas, and we need to address that. But once the patient's been appropriately decontaminated and moved through the decontamination line, then there shouldn't be any further concerns at that point in terms of sort of continued exposure. There are different ways to check for nerve agent. There are things called M8 paper and M9 paper. Excuse me. These are military-grade things that you can use that you can swab, and you have a certain reaction depending on whether or not the nerve agent is present. Again, you can use these, but going just based on the clinical presentation is helpful as well. All right, so how do we treat these patients? Well, generally, if we're talking about vapor exposure, these patients, given the lethal dose, are either going to die or recover quite quickly with appropriate therapy. Now, there are all sorts of protocols that you can find, and I'll make reference to some websites and books that you can use that talk about how much treatment to give depending on what symptoms they show. So, are they unconscious, convulsing, myotic, and have profound pulmonary distress? Or do they have some, mild meiosis but no other symptoms? And you can vary the amount of treatment you give depending on how much atropine you use based on that. Certainly, I think we want to keep things as simple as possible for ourselves and our providers in the field. And that would suggest that, you use a pretty standard treatment for everyone. But if someone's exposed to vapors and, it's been longer than a couple of minutes and they look okay, they probably are not going to get profoundly worse after that. The ones that are going to get profoundly sick and die, it's going to happen very quickly with vapor exposure because of how the nerve agent works. So supportive care, especially respiratory, whatever we can do for these patients to support their respiratory effort, especially in the context of perhaps not having access to as much antidote as we might need. So we're going to talk in a second about atropine as well as Tupan, and certainly we carry these on our ambulances and they're carried in the national stockpile. But at the end of the day, it may be that we need a much larger amount than we even can find in our hospitals. So supportive care is going to be very important in addition to whatever antidotes we can have access to. Now, anticholinergic therapy, this would certainly be atropine. This is going to dry the patient out and is used in substantially higher doses than we're used to using. Really, in general, our normal use of atropine is probably either 0.5 or 1 milligram. And there are case reports of patients over the course of a prolonged treatment getting up to 1 gram of atropine. That would be 1,000 milligrams. So much higher treatment regimens than we're used to, and really we're titrating to effect. Oxime therapy, the Tupan, this is designed to try to release the nerve agent from its binding site. And again, depending on which agent you have been exposed to, an aging process happens where at some point the agent becomes irreversibly bound and the Tupan will no longer work. But nonetheless, we still recommend giving it just as a matter of making the treatment recommendations uniform. And then finally, anticonvulsant therapy. We'll talk about this in a second. These patients can have very severe seizures and convulsions as a result of nerve agent exposure. And one thing we know is that these can be quite recalcitrant and quite difficult to treat. Now, the treatment doesn't necessarily change at all. It's benzos. But the case reports can indicate that these patients require substantially higher doses than they might otherwise require for sort of your run-of-the-mill seizure treatment. So one of the things that we kind of take away from this is the treatments we use for nerve agent exposure are not particularly revolutionary, but that we do require substantially higher doses of them than we would for other things that we treat with the same medications. So let's talk about probably the most important agent, and that is atropine. Atropine is a drying agent. It's an anticholinergic agent. It is designed to compete for the muscarinic receptors and try to dry the patient out. Really, you're titrating this to effect. So in terms of how much to use, generally you're going to start high and go high and continue high. Normally we would use, again, 0.5 to 1 for what we normally would treat with atropine. Here, your starting dose is probably going to be 2 milligrams. If you're using an auto-injector, generally they have about 2.1 milligrams in them. And this is your starting dose. You are going to repeat this as many times as necessary to dry the person out. Now, do they need to be completely free of secretions? Probably not. But their respiratory effort needs to be improved to the point where they are able to exchange gases on their own, and that's going to require that their secretions decrease substantially. So you're going to use 2 milligrams and repeat it as necessary to dry their secretions out. If you think about how much atropine you carry on your ambulances, that you have in your code carts, or even that your pharmacy has access to in your hospital, this could be a large problem. I think it's more of a challenge for us in the pre-hospital environment in the sense that if there's an exposure and we're treating lots of people, again, the necessity of treating this early is critical, and it may not be as much of an issue in terms of how much we have in our hospital pharmacy unless we're mobilizing that into the field. I'm not sure there's a good solution to this other than assessing your risk and stocking atropine appropriately. The amount that we have on a rig is probably not even enough to treat one patient. And the amounts that we'll need to treat multiple patients or to give repeat doses is far going to exceed what most systems have access to. Now, having said that, we also know about things like the strategic national stockpile, and we know about the stocks that our hospital pharmacies have. And these are potential agents that we could use as well. Certainly, these patients are likely going to be requiring continued atropine dosing while they're in the hospital. But in terms of mobilizing any of these resources for use in the field, I'm not sure that can happen quick enough to make a significant difference. And the other thing I would caution you to think about is there going to be a requirement, is there going to be an agent to treat yourself? So some people would argue that the first doses of atropine on a rig or that are pulled for an incident like this are going to be used to treat the responders and not necessarily the patients. And in fact, that may be a protocol in some cases that you have enough for your responders as well as patients. But nonetheless, it should be clear that you need a lot of atropine, a lot more than most of us have access to easily. And you can see the pediatric starting dose, 0.25 to 1, again, titrated to effect. Now, one of the concerns, of course, is, when giving atropine, am I going to see heart rate increases and so forth? And well, yes, obviously that's true. That's one of the reasons we use atropine otherwise, of course, for bradycardias. But in this case, we're titrating to effect, and that's drying of secretion. So we're not going to be quite as concerned about how tachycardic they get. And instead, we're going to be concerned about how do they look clinically. So certainly, you can expect the heart rate to go up, and that is not a concern given kind of our overall goal to dry them out. Use as much needed. The patient should be able to breathe easily. There are several auto-injectors on the market. They all are reasonably expensive, as you might guess. Auto-injectors are. The Duodote, which we'll talk about in a second, which has 2-PAM and atropine in it, starts with 2.1 milligrams. Some protocols, in fact, the one that I think people should subscribe to in terms of stocking suggests that you should have 3 auto-injectors for every patient that you expect to treat in the field. That's a lot. And clearly how expensive these are, that's probably not practical. But in terms of thinking about protocols and some of my work with the DMAT teams, what we have available, it would suggest that you should have at least 3 auto-injectors for yourself, let alone any people that you expect to treat. This says redose is needed every 5 minutes. The first time I did this presentation and did some research on this, that was the guideline. I think probably now some of the newer research suggests that you probably shouldn't wait quite as long. It's reasonable to wait probably 2 minutes to 3 minutes and then redose after that. And you can see that usually 15 to 20 milligrams will be the maximum. However, that's usually and certainly not a hard and fast rule. As I said, people who have had profound exposures will require atropine in the hospital setting. And again, there are case reports up to 1,000 milligrams, which I think would probably exhaust any even well-equipped pharmacies. So we certainly need to be thinking about that. In addition to what we use in the field, what are we going to do with these patients at the hospital? It may be advantageous for you to talk to your pharmacy and just say, hey, by the way, how much atropine do we have accessible to us at any given time? And to find out the answer to that. One of the ways to solve this problem, there are other types of atropine. So most of us think about the box of atropine in our code cart, which obviously does not have a large dose on it, but you can buy vials of atropine, obviously, and there is even atropine that's available in what you call a dry or a powdered form that can be reconstituted, and that may allow you to have a larger supply on stock. So certainly something to think about in your protocols, and it's also something to think about in terms of what to do at the hospital setting. All right, so let's talk a little bit about the other therapy, which is oxime therapy. So as we know, the nerve agent binds to acetylcholinesterase, and that will age quickly. So some agents are going to bind and quickly become irreversibly bound to the acetylcholinesterase. And it doesn't matter how much 2-PAM we give, there's not going to be a release of that agent. Other agents bind more slowly, and the 2-PAM is going to be effective. without knowing specifically which agent you're dealing with and without taking the time to try to figure it out, it's reasonable to treat with both atropine and 2-PAM in all cases of nerve agent exposure, with the understanding that if the agent is already irreversibly bound, you're not going to cause any harm except for perhaps some hypertension with the oxime therapy. So what we're trying to do here, again, is to restore the catalytic activity of the enzyme and to try to, again, split the nerve agent off from that. So these work quite well together in the sense that one treats the symptom and one tries to treat the underlying problem. And now that we have an auto-injector that has both in them, that certainly can make life easier for you. Oxime therapy, there are a number of different oximes. The one we usually use is 2-PAM chloride, so pralidoxime chloride. The starting dose is 600 milligrams. Now, there is some controversy about how this is administered and the effects you have from it. So we do know that people who get 2-PAM can get hypertensive. So could this precipitate perhaps a hypertensive urgency or emergency? Well, yes. But as we talked about with the atropine, we're treating for symptoms here, and the fact that the patient gets a bit tachycardic and hypertensive is probably something we can address later on and should not prevent us from using this. The problem is that it depends on how quickly the drug is given. So generally, when you're giving 2-PAM by itself, it should be run in over about 20 to 30 minutes, and that minimizes the amount of hypertensive response you're going to see to it. Well, that's fine, except when you're using an auto-injector, which obviously is going to administer in about 10 seconds. So the auto-injectors that we use that combine 600 of 2-PAM with 2.1 milligrams of atropine are convenient, but they also are going to make people more prone to hypertension because of the speed with which the 2-PAM is given. Something to think about. I don't think this changes your therapy. I think the auto-injectors are perfectly appropriate to use. But again, you're going to be giving it much quicker than you would sort of standard give it, and you may see some more profound hypertension from that. Certainly, I wouldn't advocate that you need to be too concerned about treating it in the kind of in the acute setting, but most of the case reports and papers talk about using phentolamine to treat that. So hopefully that makes some degree of sense. There, again, this is trying to split the nerve agent from the acetylcholinesterase, but we do need to talk about this concept of aging. So aging, the idea is that the moiety loses a side chain, and once this side chain is lost, oximes are no longer effective, and that's because the binding of the nerve agent to the acetylcholinesterase is now irreversible. So as I talked about, it ranges. GD is 2 minutes and VX is 22 days. Now, clearly, we're not going to be sitting on scene and trying to figure out, okay, was this GA or GB and how long has it been? Should I give the 2-PAM or not? So I don't really see a need to think about this too much in the field, other than to suggest that depending on which agent people have been exposed to, 2-PAM might be effective or it might have absolutely no effect at all. Certainly, if you're dealing with VX and you have a half-life of 22 days, there's plenty of time to get the 2-PAM in, and it'll have a rather profound effect. Whereas if you're dealing with some of the G agents, you don't have nearly enough time. 2 minutes, there's certainly not much of a chance of getting the 2-PAM in within 2 minutes of exposure, unless perhaps you're using it on yourself. That does then require the enzyme regenerate, and we know that that can take weeks. So one of the questions that some people often ask is, how long will the symptoms persist from exposure to nerve agent? Well, obviously the atropine is going to be used to dry the patient out, and that we're certainly hoping will take effect quickly. These patients can be myotic and have some visual disturbances for quite a long time. There are case reports of patients having some degree of miosis and some degree of visual impairment for weeks after this. And so it's very interesting that, again, it's one of the most sensitive signs to use for exposure. You can see how persistent it is. And it's something I would encourage you to include in your protocols, that anyone when you're concerned about vapor exposure, miosis is the first thing you check. All right. We also want to talk briefly about the anticonvulsant as we are wrapping up our discussion here. So again, these patients can have profound seizure activity and status epilepticus from nerve agent poisoning. The FDA has not approved midazolam, at least the last I knew, had not approved midazolam for status epilepticus, but I think we all know these days that that's probably the best drug to use. You can get auto-injectors for these, or you can certainly have it drawn up. But again, you're going to need to probably use a profoundly larger dose than you would otherwise. There are some protocols that advocate that your first dose of midazolam should be 10 milligrams to try to treat a seizure that's been related to nerve agents. Certainly, you can obviously base that on your own practice pattern, and again, you're going to titrate to effect. The diazepam autoinjectors, as you see, carry 10 milligrams. I don't, again, think it matters all that much, but I do think the evidence is good that midazolam is probably the best agent for that. Certainly, we're no strangers to using things off-label, but I'm not advocating that in this presentation, of course. So again, not trying to advocate any particular one therapy, but the most common thing that can be used today is Duodote. It's an auto-injector. It's available to both the military and first responders. It's a one needle, one injection therapy, which I think is useful. You certainly can still buy atropine auto-injectors and 2-PAM auto-injectors, but this one provides 2 milligrams of atropine and 600 of 2-PAM in one injection. Now, as we talked about earlier, I think it's reasonable to think about having 3 of these for each person you expect to treat. 1,800 milligrams of 2-PAM, which is what you get in 3 injections, is what we try to limit ourselves to anyway. So this makes it reasonably convenient to have to administer this. This would give you 6 milligrams of atropine, which should be enough, hopefully, to start to dry the person out and give you enough time to get to whatever facility you're going to if you're out in the field. But again, if you think about having to purchase 3 of these just to treat perhaps yourself or the first victim, this quickly becomes a very, very expensive proposition for treating a lot of people. And this again, I'm not sure there's an easy solution to this other than thinking about what your risk exposure is. And there you can see that, the Duodote. Finally, let's talk about long-term outcomes. There's certainly this has not been studied extensively, obviously, but as time has gone on, we've been able to see more and more data from Japan, given that the attack was quite a number of years ago at this point. And I would emphasize and draw your attention to the third bullet on here. Clearly, I should probably emphasize this more than I do in the slide. Neurobehavioral symptoms, PTSD, long-term neurologic and in some sense psychiatric disability is clearly associated with exposure to nerve agents. So they're seeing this very clearly in Japan. These patients have these neurobehavioral syndromes and have PTSD, certainly from the exposure itself, but also likely from some chemical changes. Now, we're not necessarily talking about kind of a post-stroke syndrome where they have overt neurologic findings, but it's really more neurobehavioral and almost psychiatric. And they've not necessarily coined a term for this yet, sort of a post-nerve agent syndrome, but we clearly are seeing evidence of this as the most predominant long-term symptom in these patients. Hypoxic encephalopathy, well, that obviously relates to seizures and so forth. But if we can treat patients quickly and if we have enough medication to treat them, many of these folks recover without any long-term complications or not to minimize it, but no long-term physical manifestations, so to speak, aside from the neurobehavioral syndrome. The last thing I want to talk about is prophylaxis. This is a fairly controversial topic, and I would direct you to not only some of the papers that I've referenced, but also the military effort. This is where this is being studied extensively. You can, in theory, give pyridostigmine to be administered prophylactically when a nerve agent exposure is expected. So unlike nerve agents, this is reversibly bound to acetylcholinesterase. And if you think about it, it will prevent the nerve agent from binding to the enzyme. This is certainly not a standard protocol. It's certainly not something I'm necessarily advocating that we think about in the field, but it certainly has been used by the military and is referenced in the military literature. And it has a number of potential benefits. If you think about it, the effects you're going to get from pyridostigmine are not going to be anywhere near as severe as the effects you're going to get with nerve agent exposure. It certainly is a bit more readily available. And I think if it proves to prevent some of the exposures, perhaps especially in first responders, it may be something that we need to think about. I have not advocated this in protocols in my own practice yet, although it is something that I am constantly reviewing the literature to see if there's more about this. So kind of a contemporary discussion. It's 30 milligrams every 8 hours. Again, obviously this is completely off-label, but it is interesting that people are thinking about this, especially for preventing exposure in first responders. So let's summarize our treatments. Minimal symptoms. You can give 1 duodote, observe. Again, if you're suspecting this, and if it's a vapor exposure, which is what most are, really the first thing you should be checking is, are they meiotic? If they're not, they certainly need to be monitored, but the chances of them having any severe sequela, if they don't have meiosis right when you check them, are very, very slim. Severe symptoms, I would give them the 3 duodotes. I'd intubate them. I'd give them a lot of diazepam or Versed, depending on what you're carrying. And I would be prepared to repeat those and transport them to the hospital. Again, decontamination is essential in these patients so that we don't introduce this into the healthcare setting. What do I do if I don't remember? Well, I'm always certainly happy to field phone calls, but short of that, there is an app for that. So if you don't have Wiser on your phone or device, you should download it. It's WISER, and I expect probably some of the folks on this conference have it, but if not, search for it and download it. It has everything you could possibly want to know about every type of WMD exposure, broken down into chemicals and what to do and what not to do, and it's a tremendous resource. Probably should go along with your ERGs that we carry in our vehicles in terms of from the medical side of things. So it's Wiser, WISER. It's put out by the government, and I would highly recommend that. And then those 2 websites are websites you can pull up that have disaster resources and links to different sites for solutions, and there's the link to Wiser as well. So with that, extraordinarily dangerous. There's still a more than substantial stockpile in various parts of the world. Of course, there's probably certainly agent that we don't know about as well. And immediate therapy is crucial and can mean the difference between life and death. So with that, thank you. And if anyone has any questions, I will see if I can answer them.
Perfect. Thank you, Chris. If you have any questions, go ahead and unmute yourself now. I did put up one link for Chempacks. I know Chris is mentioning about pharmacies not having enough atropine. I think that's a really good point. If this ever does happen, God forbid, I think local hospitals will run out of atropine and treatments extremely quickly. And Chempacks are kind of local strategic stockpile supplies of auto injectors for these events. I know the Chempak we have at Upstate has 2 parts, one for the hospital and one for the EMS community, where the Onondaga County Emergency Management can ask for these to be distributed, or someone else from the region can, and they can be rolled out in short order. How short, I don't know, but at least in hours, not days that the SNS would take to get to us from the CDC.
Yeah, I think that's certainly appropriate. It gets back to timing. Is hours I mean certainly that's quicker than the SNS, but is that going to be appropriate to, use in the field for exposure? I don't know. So I think, it's a very difficult situation that we don't really have a good solution to in terms of if this were to happen again, where would we find this medication?
I think you're right. I think we won't know until it happens. We have it available, but you're right. This could be a very quick over and done event before we even roll out drugs or antidotes to the region. But if we can, we'll have it available otherwise. I also put up the Wiser link, and I found your Bag the Puddles acronym somewhere. And
okay.
Put that in the chat page as well.
Lost track of all those.
There's lots of them. So yeah. So just so you know, for next month, June 30th, 1 p.m., we got Dr. Martin Gill from UPMC. He's going to be doing flight physiology. This is going to be a little different type of topic. It's going to be more, I believe, board review type preparation for the EMS physicians out there. He sent me the slides a while ago, and they look very good, and they're full of good information for board prep and basic flight physiology for providers like Chris Tanski, who does air medical transport on a frequent basis. So I think he'll do a good job. I think that's it. Last chance for questions. 3, 2, okay. Otherwise, we'll thank Chris Tanski. He did a great job. I knew more now than I did an hour ago about nerve agents, and I think it went very well. So thank you very much, and we hope to see you next month.
Have a good day, everyone.
And stopping.